have the pleasure to introduce our next speaker. And our next speaker is Professor Tarek Abdel Hadi Ali, and he's from Egypt. Thank you very much, Professor. We cannot hear you, Prof. Can you unmute?
Mute, yes. Can you hear now?
Yes, yes, we can hear you now. Welcome and thank you for your presentation.
My screen is clear.
Yes, we hear you clearly.
Okay, so first of all, I would like to thank the UCG organized committee for inviting me to share my knowledge and my expertise in this scientific event, and it's actually my pleasure to be here with you today. Let me first of all highlight this is Egypt, of course. This is the logo of my university, Cairo University. This is its logo. So, okay, let's start with this. I hope that my presentation will be exciting and stimulating to all the attendees and the audience, especially that it is about a rare clinical topic, and I hope that it will be stimulating to all of you, increasing the clinical awareness of physicians and all healthcarers to this topic, the topic of neuroendocrine tumors or neuroendocrine neoplasia, and to improve the clinical care of such patients suffering from such a clinical entity, the neuroendocrine tumors. This is my disclosure. This presentation has no commercial background and I have no financial conflicts of interest to declare. That's fine. The outline of my presentation will be definition and epidemiology of neuroendocrine tumors, the causes, types, and the classifications of neuroendocrine tumors, the pathobiology of neuroendocrine neoplasms, and the clinical behavior spectrum of neuroendocrine tumors, the metabolic effects of neuroendocrine tumors and its clinicopathologic aspects, and the clinicopathologic aspects of the paraneoplastic syndromes, and the impact on the diagnostic approach and management of neuroendocrine tumors, and then concluding remarks. First of all, we have to understand what is the neuroendocrine tumors. I mentioned that the neuroendocrine tumors actually is a rare clinical entity, although in the current time we are recognizing more cases of
Sorry, you should share your desktop.
My desktop? Yeah, I'm sharing my desktop.
If you don't see anything.
So now it's okay?
No.
I'm clear? I'm clear now?
No.
No, down at the bottom you should see a green button that says share screen.
Ah, yes. Now it's okay?
Nope.
Share. Now it's okay.
We're getting there. Now it's okay, we can see your desktop.
You can see my desktop now?
Yep.
That's fine. So I said that the neuroendocrine tumors, they are tumors which arise from the cells of the neuroendocrine system, and these cells are actually widely distributed throughout the body, either in the form of aggregates in certain organs or in the form of cells which are almost in every cell. And
could you maybe go to the full screen, please?
My full screen? Yes, I'm in the full screen now.
No, we see your desktop.
This one. Actually, I don't have the IT with me, so.
Check the chat There's a message to guide you.
Which one?
Prof, just the chat. There's a message on chat to guide you how to make full screen. Your PowerPoint.
Yeah,
At the bottom, the toolbar, that PowerPoint. Just read the chat, Prof.
which one?
The PowerPoint screen.
The PowerPoint screen.
Click on the PowerPoint screen at the bottom.
Okay.
Go down, down. Bring your cursor down to the orange, yeah. Go further down until you see the PowerPoint screen.
Yeah, this is the PowerPoint.
No, towards the end, towards the end.
You want me to show it, maximize it?
Yes. On that, click on the PowerPoint screen.
Okay,
That's better.
It's fantastic because I'm a little bit ignorant in such issues sometimes. I need IT with me. So let's go back to I said that the neuroendocrine tumors actually, they can arise anywhere in the body, and they although they are rare and they can occur anywhere, as I mentioned, but their paraneoplastic presentation, which is the issue which I want to focus on today, is rather common. And actually, although they are rare in clinical incidence and prevalence, the neuroendocrine tumors, their paraneoplastic presentation is common. And the most common tumors presenting with paraneoplastic features is the neuroendocrine tumors. Most of these tumors are actually encountered in the lungs or in the gastrointestinal tract. And then comes the pancreas, the appendix, or in the colon and other sites in the body, like in the mediastinum, in the retroperitoneum, in the breasts, and even in the skin. So, as we can see, it can arise anywhere. And its paraneoplastic features also, which I will discuss, especially the endocrine manifestations or the endocrine and metabolic presentation of neuroendocrine tumors, they are rather common, and we should always put in mind these clinical features of the paraneoplastic presentation of neuroendocrine tumors whenever we meet a case suspicious of having a neuroendocrine tumor. So this is as regards the definition and the origin. Actually, there are about 15 different cell types which are defined by various hormonal products or are defined by its synthetic products biochemically and pathologically. And many terminologies are used in describing these tumors, and they are used exchangeably by both clinicians and pathologists, like the enterochromaphenomas, argentaphenomas, the apopodomas. And the apopodomas means the amine precursor and uptake and decarboxylation derived tumors. We call them apodomas, or argentaphenomas. All these are different terminologies which are used exchangeably to describe the same thing, or what we call the neuroendocrine tumors. The exact cause of the neuroendocrine tumors, how does the neuroendocrine cell start to behave and produce and being transformed into a tumor? Actually, the exact cause is not known, but whether it is genetic or environmental or both genetic predisposition is important, and then come environmental or acquired factors which initiate and then induce the progression of the tumor. All of these factors might play a role in the initiation and propagation or progression of a neuroendocrine tumor. But it usually starts with some insulting agent which stimulate the DNA inside the cell, and we all know that the DNA gives information to the cell to what to do. So this information or this stimulus or this insult which irritates the DNA will give order to the cell to start to reproduce autonomously and form the tumor. And as I mentioned, there are many factors. It might be genetic factors. That's why, as I will mention, we have to genetically characterize these tumors and look into the family history in every individual case because of the possible genetic background. So genetic factors play a role, whether in a sporadic way due to mutation in the gene or due to a familial cause. And in these familial cases, we usually find the tumor more widespread in the body or multiple. That's why when we see a case of a neuroendocrine tumor, one of the important issues we should answer it clinically, is it solitary or multiple in this individual? Does this patient has this tumor as a solitary tumor, or does he have other multiple tumors in his body? The genetic factors play a role in the sporadic cases, solitary cases of neuroendocrine tumors, and in the familial cases as well, presenting with multiple tumors, as I will say. Environmental factors also may play a role, whether there is an interaction between the acquired environmental factors coming from exogenous, coming from outside the body, microbial, chemical, dietary, interacting with what we call the neuroendocrine gut interface. These environmental factors will start to trigger the formation of the tumor and its progression, especially if we know that the biggest part of the neuroendocrine cells are actually situated in the submucosa of the gastrointestinal tract and in the submucosa of the tracheo-bronchopulmonary system. What we call the Klatsky cells, and these Klatsky cells, they are argentaffin positive cells or enterochromaffin cells, which are present in at the epithelial interface of the gastrointestinal tract and in the tracheobronchial tree as well, in the respiratory tract. So the interaction between the genetic factors and the environmental factors may play a role in the initiation and progression of neuroendocrine tumors. Also, the interaction between the central and the peripheral neuroendocrine system might play a role, especially the role of the hypothalamo-pituitary axis in the pathogenesis or in the etiopathogenesis of the tumors, or in the modification of its clinical course and biological behavior. It's not clearly understood the interaction between the central and the peripheral neuroendocrine system. Especially, as I mentioned at the beginning, that the neuroendocrine cells actually, they share the traits of both nerve cell and the hormone producing or endocrine cell. They are stimulated, or they receive nerve impulses, and they respond by sensitizing and secreting hormones or hormone-like substances. And this is very interesting. So there might be endocrine, paracrine, or even autocrine factors which play a role in such tumors. What are the exact interaction between the hypothalamus pituitary and the peripheral neuroendocrine tumors is not yet clear, but this has to be investigated more in order to understand better the natural history and the pathobiology of the neuroendocrine tumors in general. Also, there might be an interplay between the neuroendocrine system and the immune system, especially in the initiation and the occurrence of paraneoplastic features, as I will mention later on. Actually, there are many types and the classifications of systems of neuroendocrine tumors, and there is no single consensus on the classification of neuroendocrine tumors in general. Actually, neuroendocrine tumors, it is a textbook by itself. It's not as many physicians think it is just a chapter in a book of endocrinology and metabolic medicine. No, it is a textbook by itself. Because of its wide spectrum, the neuroendocrine tumors is a wide spectrum medical problem. It is not a single disease entity. We can say it is rather like a syndrome with different types, different etiologies, and different clinical presentations. And it is a very big heterogeneous group of disorders. Although, as I will mention, the most common and the well-characterized type of it is the carcinoid tumors. But the spectrum of the neuroendocrine tumors in general is much, much bigger than being confined and being imprisoned only in the carcinoid tumor issue. The classifications are different. As I mentioned, there is no single consensus between the Western medical schools and the Eastern medical schools. The Japanese have their own classifications. The Western Europe has its own. The Americas has its own, and it all depends on what is the criterion used to classify and categorize the neuroendocrine tumor. Is the classification based on the location of the tumor, or is it based on the type of cell of origin of the tumor, or is it based on the hormone secreted or the hormone-like substance that it is, whether it is functioning tumor or non-functioning tumor, or is it based on the pathologic behavior or the biologic behavior and the pathological features of the tumors? That's the histopathology and the electron microscopy of the tumor. All of these criteria are used by different organizations for the classification of neuroendocrine tumors. Although the most important for the neuroendocrine tumor is to locate it and to pathologically categorize it and to physiologically categorize it, whether it is secretory or non-secretory, and if secretory, is it secretory with sufficient amounts to produce a functional endocrine, clinical endocrine syndrome or not? That's functioning or not functioning. So is it solitary or multiple? Is it benign or malignant? And is it functioning or not functioning? This is very important. I will come back to the issue of benign or malignant. We can say that almost all of the neuroendocrine tumors are malignant neoplasms, or at least potentially malignant. Although many of such cases at the beginning may behave like a benign tumor if they are detected early in the course. Some of these neuroendocrine tumors, they look like benign at the beginning of the clinical course. And then at some stage of their clinical progression, the real malignant phase will start to appear. That's why we have to put any case encounter suspicious of having, and the clinicians start to think that this patient might have a neuroendocrine tumor. After the diagnosis of the case, we should put the patient under observation. And here under observation is the art of medicine, is the art of management of such cases. Cases suffering from a neuroendocrine tumor, or if they are clinically suspicious of having a real neuroendocrine tumor, especially if the neuroendocrine tumor is detected early, because some of them early in the course of the disease, they look like benign tumors. But they are almost all of them, especially those presenting with functional syndromes, they are malignant, or at least potentially malignant, as I mentioned. The classifications, there are two major classifications adopted by the Western organizations. One adopted by the WHO, and the last one was in 2017. And they classify, I mentioned here, there is one there was a meeting in 2016 and another one in 2017, classifying neuroendocrine tumors based on the degree of differentiation and proliferation of the tumor cell types. And here they consider the pathology of the tumor in its classification. And we have what we call the memorial slow and Kettering system, and this is another system. Also, this system considered the pathobiology of neuroendocrine tumors, that they are might be classified into well-differentiated, and the well-differentiated are further classified into typical and atypical neuroendocrine tumors, and then the poorly differentiated, and these are further classified into small cell type and large cell type. But the well differentiated, they are rather low grade tumors or intermediate grades at most. And then the poorly differentiated, they are all carcinomas, and they are either small cell or large cell, and all of them are high grade malignancies. So this is the broad classification of, we can say that there is semi-consensus on it, that it is classified into poorly, well-differentiated and poorly differentiated, and well-differentiated into typical and atypical, like typical and atypical carcinoid, or typical and atypical neuroendocrine tumor, and the poorly differentiated, which is either small cell type or large cell type, like the small cell neuroendocrine lung cancer and large cell neuroendocrine lung cancer. Especially if we know that most of these tumors arise in the gut, the gastrointestinal tract, especially in the jejunum and ileum, and then comes the appendix, or in the, as I mentioned, in the respiratory system. And many of the lung cancers are neuroendocrine lung cancer, whether it is bronchial carcinoid or typical carcinoid, or bronchial atypical carcinoid, or bronchial small cell lung cancer, or bronchial large cell lung cancer. These are neuroendocrine. So neuroendocrine tumors should be considered actually in the differential diagnosis of gastrointestinal cancer, and also in the differential diagnosis of pulmonary cancer. Many of them are neuroendocrine tumors, in fact. The clinical presentations or the spectrum of the neuroendocrine tumors, it depends on the location of the tumor. It depends on the whether it is functioning or not functioning. The tumor is secreting a hormone or hormone-like substance to present with clinical features of an endocrine disturbance or endocrinopathy. And here comes the endocrine presentation of the neuroendocrine tumor as one phase of paraneoplastic presentation of neuroendocrine tumor. And as I mentioned, paraneoplastic means it's a systemic, non-metastatic presentation of the tumor. It is a systemic, non-metastatic presentation of the tumor. We say it, or we call it paraneoplastic. And the commonest paraneoplastic presentation is an endocrine presentation, that is with endocrine dysfunction or features, symptoms and signs pointing to an endocrine problem, as I will mention. But the neuroendocrine tumor might either present with, as I mentioned, depends on the location, it depends on the biologic behavior, secreting or non-secreting. It depends on also whether it is malignant or it is still in the benign form that is not invasive, not rapidly increasing in size. So all of these things, where it is and how it is acting and biologically behaving, and what is its physiologic characters, that is secretory or non-secretory. All of these features determine how the tumor will present clinically. So it might present with as a mass lesion. It might present, for example, neuroendocrine tumor in the gut might present with pain, might present as swelling, might presenting with hepatomegaly if it is associated with metastatic disease in the liver, especially with mid-gut neuroendocrine tumors in the jejunum or ileum. Or it might present with like a mediastinal mass in cases of a neuroendocrine tumor in the thymus, or it might present with lung opacity if it is, or hilar opacity if it is a neuroendocrine tumor of the bronchial tree or tracheobronchial tree. It might present with abdominal pain, it might present with chest pain, it might present with other local features even in the skin. It might present as a skin lump if it is a neuroendocrine tumor in the skin, or if it is, for example, neurofibroma. Neurofibroma is a part of the neuroendocrine tumors in von Recklinghausen syndrome. It might present as a lump in the skin. So a lump in the skin, a lump in the chest, a lump in the abdomen might all be suspicious of being a neuroendocrine tumor. And this is very fantastic to think about. Any lump or any pain might be due to neuroendocrine. We have to put the neuroendocrine tumor etiology in our minds always in the differential diagnosis of any pain or any swelling in the body. Actually, as I mentioned this, I have mentioned this, that might be well differentiated or poorly differentiated in the setting of carcinoid tumors being the most common, actually the most common clinical neuroendocrine tumors clinically met with is the carcinoid tumors. We have to think about the carcinoids. Carcinoids in the gut versus islet cell tumors in the pancreas versus carcinoids in other sites. I mentioned this is very important. There is what we call the carcinoid-related spectrum, that it involves also not only the carcinoids in the gut and the carcinoids in the lung. We might see carcinoids in the pancreas, and this is considered among what we call the pancreatic islet cell tumors. They might be carcinoids, they might be gastrinomas, they might be insulinomas, they might be vipomas, they might be glucagonomas. All these are put by some authorities in the what we call the clinical spectrum of carcinoid syndrome. And each of these categories, they have their own biologic behavior. Then we come to what we call the paraneoplastic syndromes. And the paraneoplastic syndromes as a presentation, I want to focus on this, and this is the second part of my talk, is about the paraneoplastic syndromes and how it can be a presenting feature of the neuroendocrine tumors in general and the carcinoid syndrome in carcinoid tumors in particular. I mentioned that these are humoral non-metastatic effects of the tumor. They are due to systemic or metabolic effects, and we all know this, which is related to the substance being elaborated by the tumor, and this might be very heterogeneous. It might be a hormone, it might be a hormone like substance, it might be a cytokine, it might be other metabolites, or it might not be produced directly by the hormone or the metabolic substance secreted by the neuroendocrine tumor, like the serotonin in case of the carcinoid syndrome, that's the 5-hydroxytryptamine, and the other amines and the other peptides and even prostaglandins secreted by the carcinoid tumors. No, it might be actually induced by what we call neuroendocrine immune interaction, that it is immune mediated. And this is very, very interesting. That's the interaction between the neuroendocrine system and the immune system, and its role in the pathogenesis of the paraneoplastic features in such tumors. So it might be immune mediated. And this is especially the issue actually not in the endocrine manifestations, in the neurological manifestations of the tumor. Thus we can say that all of the neurological manifestations of a neuroendocrine tumor are due to immune system dysfunction, interaction between the hormones and the immune system disturbing the cytokines and the leukotrienes and the other neurotransmitters, resulting in the neurologic manifestations. The endocrine manifestations are rather directly produced by a hormone or hormone-like substance, not by an immune dysfunction. The paraneoplastic syndromes, it can be a presentation of any tumor, not only of any malignancy, of any cancer, not only the neuroendocrine tumor, but in the issue or in the setting of a neuroendocrine tumor, it is the most common presentation. But in other solid cancers which are not endocrine, it is a rare manifestation. But it can be the presentation of the tumor. The paraneoplastic features may be the first presentation of the tumor, or it may coincide with the diagnosis of the tumor, or it may appear later on after the diagnosis, that the patient is already known to have the tumor and then diagnosed before, and then he starts to develop features suggestive of paraneoplastic manifestations. Or, and this is the most challenging in clinical practice, it might be the presenting feature. The patient might present with the paraneoplastic features rather than by the tumor itself, and rather than by the metastasis. It's not the primary tumor which is manifest as a lump or as an incidental finding in an X-ray or on CT or on ultrasound, and not presenting by metastatic features by lymph node metastasis or hematogenous metastasis in the liver, in the brain, in the bones. No, it is presenting by systemic, non-metastatic features due to immune dysfunction or due to hormonal disturbances, whether neurological or hematological or other features. The spectrum is very wide. Let me focus on the endocrine and metabolic paraneoplastic syndromes as a presentation. The most common is the number one very important issue, that the most important and the most common paraneoplastic feature of malignancy in general and of neuroendocrine tumors is fever. Fever. The patient may present with fever. So any feverish patient, we should suspect malignancy. Of course, we all know that most of the fevers are due to microbial agents, especially we are in the setting of the COVID and these things. And but it's not only microbial agents with the viruses, bacteria, fungi, parasites, blah, 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 can be the cause. No, it might be, fever might be a presentation of malignancy. And one of these malignancies is neuroendocrine tumor. The neuroendocrine tumor might first present with fever. And we have to look for an underlying malignancy or underlying neoplasm, and specifically a neuroendocrine neoplasm in any patient presenting with fever. Although it is a rare clinical entity, but when we exhaust all other possibilities, especially in the setting of investigation of what we call fever of unknown origin, we have to think of malignancy. So neuroendocrine tumor might present with number one malignancy, fever. Number two, also what we call cancer-associated cachexia or CAC. The patient presents with loss of weight. So fever and loss of weight are the commonest paraneoplastic features of any malignancy. Fever and loss of weight. And then comes other specific features like endocrine features. The most common endocrine features is the syndrome of inappropriate antidiuretic hormone secretion and hypercalcemia number two. This is what we call hypercalcemia of malignancy. And it should always be into the differential diagnosis of hypercalcemia with primary hyperparathyroidism. We know that primary hyperparathyroidism or hyperparathyroidism is the commonest cause of hypercalcemia. Number two comes malignancy. And in the malignancies, the neuroendocrine malignancies or the neuroendocrine tumors, whatever its site is, whatever. So that's why we should always, number one in the biochemistry is to look for hypercalcemia, like serum calcium and phosphate. Hypercalcemia might be the presentation of a neuroendocrine tumor. Also, the hyponatremia, and due to what we call syndrome of inappropriate antidiuretic hormone secretion, is another common presentation, another common endocrine presentation of a neuroendocrine tumor. And then comes the features, or what we call ectopic Cushing syndrome. And this is a malignant Cushing, or Cushing due to not the classic Cushing syndrome due to an adrenal tumor or an ACTH pituitary producing a tumor. It is due to ectopic ACTH production by malignancy or by a neoplasm, namely by an endocrine tumor in the pancreas or in the lung or in the gut. They might be the sources of what we call ectopic ACTH. This ectopic ACTH secreted by a malignancy in the body might present as a Cushing syndrome. And this Cushing syndrome characteristically has two important features. The patient has weight loss, not the classic Cushing with obesity, no. This is Cushing with weight loss, and this is what we call atypical Cushing. Cushing with weight loss and Cushing with pigmentation or with hypokalemia, suspect a malignancy. Suspect a neuroendocrine tumor, because this is atypical Cushing syndrome. So Cushing might be a presentation, sciatica might be presentation, hypercalcemia might be presentation, carcinoid syndrome, if the tumor was a carcinoid tumor, also might be, with the classic triad of flushing, facial flushing, bronchospasm and diarrhea, with or without rapid heart rate, hypotension, and pellagra. These are the features of the carcinoid syndrome, plus or minus the carcinoid heart disease. Let me go quickly, because I know that my presentation is rather very big and very having many branches, and it is multidimensional and perplexing. So I'm trying to pass quickly on different issues. It might be, as I mentioned, the presentation might be with hematological features. Especially common is the erythrocytosis. The patient might present with Erythrocytosis might present with thrombocytosis, might present with a leukomoid picture also, might present with hypercoagulability. So a neuroendocrine tumor should be considered in the differential diagnosis of any what we call hypercoagulable syndromes. Hypercoagulability might be a presentation, hematological presentation of an endocrine or a neuroendocrine tumor. This needs a lecture by itself, the hematological features of neuroendocrine tumors. Also, it might present with skin features, especially with acanthosis nigricans, with what we call neoplastic pemphigus, with pruritus, with acrodermatitis, with necrolytic migratory erythema, which is common with glucagonoma. It is a carcinoid in the pancreas. And its characteristic dermatologic features is the necrolytic migratory erythema, or it might present with erythema gyratum repens, which is also another characteristic erythematous rash in patients with neuroendocrine tumors of the gut, especially the stomach, and in some cases also of bronchial cancers. We have made this if the bronchial cancer was an endocrine bronchial cancer. The erythema gyratum repens, the necrolytic migratory erythemas, these are specific erythemas which are described in the skin in patients with neuroendocrine tumors. Also hypertrichosis and hypertrichosis lanuginosa and non-specific pruritus and the sweet syndrome, which we call it the neutrophilic dermatosis, and the Dazen syndrome. There are many dermatologic syndromes described with neuroendocrine tumors. And then comes the rheumatologic features also of a neuroendocrine tumor. As a presentation, and here is the dermatomyositis, might present as a dermatomyositis or polymyositis. It might present with leukocytoclastic vasculitis affecting the skin with vasculitic rashes. It might present with erythromelalgia. It might present with arthropathies, especially the carcinoid might present later as arthropathy affecting the big joints. In cases of chronic carcinoid, especially carcinoids of the hind gut, or it might present with hypertrophic osteoarthropathy. These are all what we call musculoskeletal features. And then we have the common neurologic also paraneoplastic presentation of a neuroendocrine tumor. The most common is the cerebellar degeneration syndromes, the focal encephalomyelitis, also common. Peripheral neuropathies might be encountered. Autonomic dysfunction might be met with. A myasthenic picture might be met with. Motor neuron disease might be met, or maybe also what we call multi-level involvement, that's motor and sensory and mixed neurologic features. In the diagnosis and the evaluation of para, I think I still have 5 minutes or 10 minutes. 5 minutes?
You can proceed. You have about 10 minutes, Prof. Ali.
I want to be short because sometimes I exceed my limits. So this is the most challenging clinically in such cases, that the diagnosis and the evaluation of para. When we meet a case which is what makes us suspicious of the tumor as being the underlying cause of a paraneoplastic syndrome. Actually, when we meet a case presenting with neurological manifestations or endocrine, or we have to suspect, especially if it is present, for example, in rheumatologic manifestations, if it is in elderly people. In elderly people above 50 years presenting with dermatomyositis or with cerebellar degeneration or with myasthenia or with features suggestive of Cushing syndrome or with hypercalcemia or with hyponatremia, with all the paraneoplastic features I mentioned, we have to suspect an underlying neuroendocrine tumor. Any patient more than 50 years old presenting with any of these paraneoplastic features, you have to suspect. Also, if there is a positive family history, so this is because I mentioned that the neuroendocrine tumor may be either solitary or may be associated with other familial syndromes. The most common is with multiple endocrine neoplasia type 1, and also in patients with tuberous sclerosis and in patients with paraganglioma syndromes. They might be more than one tumor in the body. For example, in multiple endocrine neoplasia, you will find the classic triad of parathyroid tumor with pituitary tumor with a pancreatic neuroendocrine tumor. Parathyroid, pituitary, and pancreatic neuroendocrine tumor. So we have to, if a patient presenting with a pancreatic tumor, we have to look for parathyroid, we have to look for pituitary. How will we diagnose these cases? We have to, number one, to localize the tumor. So localization is very important. So radiology is very important. We have to, if the patient is suspicious after history and physical examination, you have palpated the abdomen, you have palpated the chest, you have auscultated the abdomen, the chest, and you did the full detailed physical examination, you have to proceed to investigations. Number one in the investigation to try to localize the tumor. So localization is very important. And here comes the role of radiology. And the most important for diagnosis is after doing, of course, the plain X-rays, the plain radiography of the chest, you have to do a CT scan. If you are suspecting a tumor in the gut, you have to do, in the pancreas, you have to do number one, ultrasound of the abdomen and the pelvis to screen for any possible tumor in the abdominal or pelvic organs. If the ultrasound is negative, you have to proceed to CT with contrast. In the chest, you have to do spiral CT. You have to do sometimes PET with CT. In some cases, in order to screen more thoroughly, you have to do an MRI of the chest, MRI of the abdomen, MRI of the pelvis, and then you have to look also to look for any hormonal secretion by doing what we call hormonal assays. You have to, if you are suspecting a carcinoid tumor, you have to look for serotonin in the what we call platelet serotonin. You have to look for hydroxyindole acetic acid in the urine. If you are suspecting the carcinoid syndrome, you have to look for biomarkers, what we call biological markers like chromogranin or synaptophin or synaptophysin, which are biological markers or biomarkers secreted by carcinoid tumors. You have to look for other biological amines secreted by the tumor. You have to look for polypeptides secreted by the tumor by doing the proper hormonal assay depending on each patient. That's why the selection of investigations, which radiologic investigations, which hormonal assays, which pathologic investigations depends on your patient. That's why here comes the concept of individualization of treatment in this issue in clinical practice. As we all know, for example, in diabetes, we have the individualization of treatment. In hypertension, the same. In epilepsy, in blah, blah. Also in neuroendocrine tumors comes the concept of individualization. You tailor the management of the case according to the case. It's different. You can't put general rules, but details are different from patient to patient. But if you are suspecting a tumor, you have to proceed like this after the physical examination to the radiology, CT. You have to look for hormones. You have to start to characterize the patient also. The pathology, if it is suspicious by the plain chest X-ray that there is a mediastinal mass, you have after that to do biopsy with a CT-guided biopsy of the mass in the lung, CT-guided biopsy of the mediastinal mass. If it is a thymic neuroendocrine tumor in the anterior mediastinum, so CT-guided biopsy is very important. Or sometimes you have to do block biopsy, that's to do excision biopsy, and then, for example, take the tumor, if it is in the gut and detected by gastrointestinal endoscopy, so also endoscopy, or combination of investigations together, transendoscopic ultrasonography, or endoscopy and biopsy, all these will help you at the end to reach to the tumor, and then the definitive is to look for the pathology. So the definitive diagnosis for a neuroendocrine tumor, it's not in the clinical manifestation, it's not in the radiology, it's not in the hormonal assays, it is in the pathology. The pathology is the most important. So you have to characterize the tumor or the mass pathologically. Histopathology, cytochemistry, immunohistochemistry, look for to stain for neuroendocrine, what we call neuroendocrine markers, staining. If it is suspicious neuroendocrine tumor in the gut, you have to stain it for chromogranin, you have to stain it for serotonin if it is a carcinoid of the gut. So this is what we call immunohistochemistry and cytochemistry, and then more detailed electron microscopic ultrastructural studies. And then after the pathology comes also the genetic evaluation and the genetic characterization of the tumor, which is very important. The genetic identification, the genetic characterization, especially if we are suspecting a multiple neuroendocrine tumors in the cell, that the patient has multiple tumors inside his body, multiple neoplasms inside. We have to look for other neoplasms in the same patient. Even if he is presenting with pancreatic tumor, look for other tumors in the parathyroid, look for other tumors in the pituitary, look for other tumor in the chest, look in other tumors in the pelvis if it is in the abdomen. You have not to be narrow spectrum, you have to be more wide if you are suspecting a case of neuroendocrine tumors. So the take-home messages is that the neuroendocrine tumors need further histopathologic evaluation, electron microscopy, immunohistochemistry, and cytogenetic evaluation for more precise diagnosis. Paraneoplastic syndrome is common in neuroendocrine tumors and might be the initial presentation for variable period of time before detection of the primary tumor and before even the appearance of the metastatic disease. The neuroendocrine tumors may mimic any organic or systemic disease. It might mimic any disease. It might mimic asthma. It might mimic diabetes. It might mimic hypoglycemia, differential diagnosis. It might mimic Cushing's syndrome. It might be presenting with hypercalcemia. So consider it in any hypercalcemic patient. It might mimic erythrocytosis. It might mimic hypercoagulability. So it might mimic any systemic or clinically multisystemic disease, whether the tumor was localized or with systemic presentation. So neuroendocrine tumors should be also approached individually, as I mentioned, and individualization of diagnosis and consequently divisive therapy will be important. As I mentioned, the future of neuroendocrine management, tumor management, will lie in the better biologic and the pathologic characterization of the tumor and the better genetic understanding of the tumor and better understanding of what we call the genetic expression phenotype of the tumor in each individual patient. And this is the take-home messages in this. The clinical tips at the end is neuroendocrine tumors is a good example of the fact that medicine is both a science and an art. Here the art of medicine plays a role in the management of such cases rather than the science, because the science actually is, although it looks very big, but actually it is still little. It is still little. Whatever we are saying about the electron microscopy, the genetics, the biochemistry of the tumors, still we don't know many things about many of these tumors. Here comes the art of medicine, and the part of the art, put the patient under observation. Under observation, as Voltaire said, under observation of the art of medicine, and under observation here is pivotal in the clinical management of, you have to put, even if the patient presented early, you have to see him again and again and again, every 3 months, every 1 year, till the full picture may appear later on after 2 years. That this patient proved to have a thymic neuroendocrine tumor or breast tumor. Breast tumor may be neuroendocrine. I'm just raising the clinical alertness of how widespread the neuroendocrine tumors can be in anywhere in the body. Paraneoplastic syndromes might complicate the patient's clinical course and response to treatment also, and the treatment should target the underlying neoplasia rather than targeting the syndrome itself, that it should be diagnosis-oriented rather than symptom-oriented. We should treat the disease, the tumor, not the symptoms of the tumor, not the cost of the tumor, not the symptom, not the paraneoplastic features by itself. If we are unable to treat the tumor because it is metastatic or very widespread, or the patient's inoperable or whatever, we can help the patient to improve the quality of life by treating the symptoms. Yes, here we should be symptom-oriented, but the principle, the original is to treat the tumor itself, to take the tumor out of the body itself by surgery, by chemotherapy, by targeted chemotherapy, by chemoembolization, by endocrine modulators, that's hormonal therapies, by recently biologic therapies which target the interleukins, therapies which target the tumor necrosis factor might help in the management of such patients with neuroendocrine tumors. Smart clinician should always be active rather than reactive. And then thank you so much for this. at Cairo University, and this is the logo of my university. And thank you by all language. Arigato gozaimashita. Shukran jazilan bil-Arabic. Thank you so much. Sorry for being late.